I'm Dr. Jerome Check. I'm known as Jerome Check, MD, PhD. The PhD is actually in reproductive biology, specifically reproductive immunology, and my thesis, and it does pervade a lot of our practice, was that the role of progesterone in promoting infertility and preventing miscarriage is through the stimulation of immunomodulatory proteins. That sounds like a lot of words, but I'll try to make things clear as we talk as to what the type of practice we have and how my academic position, because I'm also a professor of obstetrics and gynecology and the division head, I'm a professor actually at University School of Medicine and Dentistry, Robert Wood Johnson Medical School, and this is the Camden division, though I'm talking to you from our private office in Marlton, New Jersey. So we blend both the academics along with clinical practice. So, for example, for myself, though I do write a lot of research papers, instead of a lot of academic physicians who maybe only see patients on a Tuesday afternoon, my hours are every day, with 3 days working till at least probably midnight, but more likely 1 o'clock in the morning, and the two, what I call my half days, I work till 7, 8 o'clock at night. When I don't take my weekend rotation as my other doctors do, but that's the time that I write a lot of the research papers. So it's constant work, but to me it's also constant fun. There are a lot of reproductive endocrine centers in the United States, but I wanted to talk about a few of the things that I think makes us unique. For one thing, I think if you've been to other places and you come here for a consult, I think you'll realize right from the moment that we don't practice herd medicine. Sometimes I joke with my students to say, if you want to be an infertility specialist or a reproductive endocrinologist, then it's a 3-year fellowship, but really I can teach you in 30 seconds. Here's what you do. Do an X-ray test of the fallopian tubes called the hysterosalpingogram, or sometimes abbreviated HSG. Make sure the fallopian tubes are open, but if they're blocked, tell the patient they need IVF. If the sperm test shows low sperm, tell them they need IVF. If they're normal, then no matter what the patient has wrong, you give them 3 cycles of the oral pill fertility drug called Clomid, 3 cycles, and do intrauterine insemination, where you wash the sperm and put it inside the uterus. And if no pregnancy, give them 3 cycles of the injectable fertility drug, what we call FSH preparations, with an intrauterine insemination, and then do IVF. And there, I think I've explained infertility in 30 seconds. And actually, that's about what 95% of infertility practices do. It's not a plan that's specifically tailored to an individual couple's problem or even into an individual couple's needs, but just what we call herd type medicine. That suits itself to seeing a lot of patients without spending a lot of time with them. When I see you for your first visit, I don't think I've ever spent less than a solid hour in talking to the patient, and that consult doesn't really just talk about gathering information, but there's a dialogue going on, and during that time I'm explaining things to you because it's important for you to understand options, because there's sometimes more than one way to fix a problem, and I need to make you aware of your nature of your problem and the options that you have. So you might say, do I really know in that first visit everything there is to know? Of course not. I can give you certain guidelines as to how we're going to find out that information, and in so doing, depending on what we find, then present to you treatment options, and then let you decide what you should do.